Yeah, good morning, sir.
Nice to have you and the team.
Yeah, thanks for
No,
joining.
it's a
Are you already in hospital or are you still driving?
no, not yet. I Dr. Shaista will drive.
Ah, okay. As always.
No, today for this, so that I can attend.
Give.
H1N1.
Now report not came. That's waiting. Not
That's
called. Didn't
okay.
tell anything. That
No.
ma'am, Shanmuga Priya ma'am.
No.
Sir told to wait. I don't ask Shanmuga Priya ma'am. I'm
So can you all see my slide?
Yeah.
Right.
So good morning, everyone. We are gathered here to discuss today on new weapon in lung transplant, that is 10-degree storage and ex vivo lung perfusion. So I'll start from the history. This was you can see on the left side, this is the first image. This gentleman first undergone single lung transplant in 1983. You can see a lady in the center. She undergone first lung transplant, bilateral lung transplant in 1986. And on my right side, the image is first lung transplant successfully done was for cystic fibrosis in 1988. This middle gentleman undergone cystic fibrosis first lung transplant. So what all the indication for the lung transplant by decade? From 1980 to 2020, there is a great change in the indication for lung transplant. Earlier, majority of lung transplant were obstructive disease and interstitial disease, and uh, um, it includes cystic fibrosis as well. But in 2020s, the number of cystic fibrosis going lung transplant has reduced significantly. Now more of the interstitial disease, 60.6% is patient getting lung transplant is of interstitial disease. This data is from the Western countries, so it has more cystic fibrosis burden where it compares to Asian country or Indian countries. This is the ISHLT data, how the number of transplant has increased from year to year. From 1992 to 2023, there is a huge increase in the lung transplant. And how the operative mortality rate has came down from 1983 to 2023. Earlier days, it was 50% mortality, early 80s and 90s. Now in 2000, mortality has significantly reduced with the increase in the number of transplant as well. This is the data from the Toronto program where it shows that in early 90s there was a steady increase in lung transplant. Then 2006 to 2012 there was a plateau phase. After 2012 there was adaptation of 10-degree lung preservation and ex vivo lung perfusion, which has improved significant numbers in the lung transplant, which helps them to take borderline organ and to travel them to a long distance, where earlier it was not possible, which increased the donor pool. So number of transplant has increased from 2012 to till now. This is a patient survival by indication for lung transplant from 1983 to 2024. You can see majority the patient mean survival is better in the pulmonary hypertension, whereas the least in the carcinoma, and intermediate is interstitial disease. So lung preservation. Lung preservation is the first step for a lung transplant, uh, for a better outcome of a lung transplant. What are the important consideration to in lung preservation? You have to consider donor consideration, anatomical consideration of lung, parenchyma, and bronchial circulation. You have to flush or not, optimal flush solution, timing, what temperature you will use, how much you will inflate your lung or not, how much FiO2 will keep, storage, how much temperature, static or dynamic, role of ex vivo perfusion, prevention consideration at implantation. When lung transplant was started, so first lung transplant was done in the where preservation was not taken in that much consideration, where lung were deflated and only topical ice slush was put, and transplant usually used to be done in the next operation theater, so ischemic time was very less. But when lung was preserved in such a manner, there was a very huge amount of reperfusion injury. So from there, now we have changed a lot in lung preservation. So how lung is different from the other organ? Lung has a different anatomical consideration. So it's a very fragile organ and it has a dual nutritional blood supply from pulmonary artery as well as bronchial artery. So only advantage lung has is that it can directly derive oxygen biodiffusion even after the circulation has been stopped. Anatomical risks are at the bronchus at midpoint, which receive blood circulation from 50% from bronchial circulation and 50% from pulmonary artery circulation. After transplant, lung is totally dependent on the 100% pulmonary artery circulation. So organ preservation strategy differs from the other organ is that all other organs is undergoes hypothermia, ischemic, and anaerobic and whereas lung goes with the aerobic because of diffusion advantage. Important consideration in lung preservation: flush or not, optimal flush solution, timing, what temperature you will use. So where other organ uses urocolin solution for liver and kidney, which is high in potassium, which we can't be used in lung because high potassium has shown that it increased the risk of endothelial injury. So this was a study which was done in a dog where both one side of the lung was transplanted with the dextrane low potassium solution, which showed that it has a better lung preservation, better PO2 even after 3 hours and 12 hours. So extracellular type of solution for lungs, low potassium dextrane solution versus urocolin solution, which demonstrated safe 12-hour preservation in dog lung transplant model, which has a low potassium and a dextrane 40. This is nothing different. This is the same as what Perfodex we use nowadays, where you can see PO2s was much better even after post-op and after 3 days when low potassium dextrane was used. Low potassium dextrane preserved solution improved lung function after human lung transplant. After this study, there was an adaptation of Perfodex solution. Earlier, they used to use UW solution, which was frequently used for kidney and liver. Importance of low potassium and dextrane 40 is its extend hypothermic lung preservation for transplant. There is a significant increase in PO2. Lungs consume glucose and oxygen and produce CO2. This was a study was done which shows that even after the lung has been procured, there is a decrease in ATP and there is increase in lactate. So it continues aerobic metabolism even after the procurement. So for donor OR recruitment, why lung recruitment is important, how much to be recruit, and how much FiO2 has to be delivered. So lung has to be inflated evenly. So your Perfodex solution can evenly distributed into pulmonary vessels and capillaries. And oxygen you have to, because as lung continues aerobic metabolism during storage, so you have to inflate adequately. So aerobic ventilation metabolism keep going at the storage time. organ flushing sequence. First, you have to heparinize the patient. You have to cannulate your pulmonary artery, followed by you have to put prostaglandin E1 into the main pulmonary artery, where you notice the drop in the blood pressure, and you continue your ventilation throughout the lung procurement. If your donor is DCD donor, no need to get panic. Keep patient ventilated. During ventilation, your lung is safer, and you can procure DCD donor as well. Lung flush technique. Bronchoscopy is the important in OR. You have to clean all the mucus plug, clean out and recruit lung properly. Intraop visualization and recruitment of atelectic area. You have to flush with Perfodex solution, 60 ml per kg, that is 3 liter. PG prostaglandin E1 at a 4-degree temperature into main pulmonary artery. Always flush the donor lung with low pressure, that is 30 centimeter. Higher pressure will lead to your capillary injury of the lung. Follow with, then you have to retrograde flush into each pulmonary vein 250 ml. And you have to store the lung in a bag with 2 liter of solution, which total come out to be a 6 liter of Perfodex to be used. And never put a direct ice on the lung. Direct ice on the lung cause higher injuries to lung and increase the risk of perfusion injury. Lung preservation not continues before implantation. It continues intra-op as well as extra-op. Outside post-op also it is that important. So liberal use of intraoperative VECMO is not to be suppressed. If a patient pulmonary artery pressure is more than 10 to 15 mmHg, better to use VECMO to reduce your pulmonary artery pressures. So to prevent PGD, you have to use proper preservation, ex vivo lung perfusion if you have advantage of using it. Intra-op ECMO use and post-op prolonged ECMO whenever required. This reduce the risk of PGD. So from the days lung preservation has started, always been used as a 4-degree centigrade. But what changed to adapt a new 10-degree temperature? Ice cooler 4-degree historical standard, inexpensive, practically easy to perform. No has been no scientific evidence to support the need for transport at normothermic. Where earlier days 10-degree continuous temperature maintaining was not easy with the technology. So 4-degree temperature was easy to be maintained with the ice around the ice box. So there are multiple studies was done which showed that 10-degree is a superior preservation for lung preservation compared. First it comes 10-degree, then comes 15-degree, and later comes the 4-degree. So this was the study was done on rabbit lung with the ex vivo, where lungs were tested on the different temperature, where you can see on 10-degree storage, your PO2, PCO2, PAP, everything, pulmonary airway pressure, everything was much better compared to other temperature. How to keep a lung at 10-degree consistently? That was a problem during initial stage of lung transplant. So it was not easily adapted. 4-degree was adapted that time. Now with the advance in technology, 10 degrees easily can be achieved. This was a study where it was done on a pig lung harvest, where lung were harvested and kept at 4-degree and 10-degree. Then it was evaluated on ex vivo for 12 hours. You can see when the lungs were evaluated on ex vivo lung perfusion with 10-degree has a better peak airway pressure. There is a less lung weight, which shows that there is a less lung edema. Dynamic lung compliance were much better with the 10-degree. You can see this is 10-degree temperature stored lung, and this is 4-degree temperature peak lung. So there was a study which showed that static lung storage at 10 degree maintained mitochondrial health and preserve donor organ function. This was same published in EGM. Later on, one study was done on the pig lung transplant model, which showed that gastric aspiration causing lung injury when it was stored with the 10 degree. After 12 hour of storage, the lung which was stored in 10 degree has a better recovery compared to which was stored in 4 degree temperature. So you can see that mean graft pulmonary vein PF ratio was much better in 10 degree compared to 4 degree. So how nowadays the majority of lung transplant in the country world is carried out in Toronto General Hospital. They have adapted a new system where even in the evening, if they got a donor call, they harvest the lung. They transport the lung in the 10 degree constant temperature. They keep the lung in the refrigerator for 10 degree storage, and they delay the transplant till the next day morning. This was the 5 case report were released, where all 5 cases were had a average time of more than 10 hours of preservation time, which has showed none of the patient has showed PGD after 72 hours, and 30-day survival was 100%. This is the recipient characteristics. You can see that those who got 10 degree storage, the PGD incidence was 5.7%. Those who were with 4 degree has a PGD of 9.3%. 30-day survival was 100%. Nowadays, most of the Western country has adopted this 10 degree preservation, where mean ischemic time is more than 12 hours. So they can increase their donor pool from traveling one end of the country to another end of the country. This is 1 year recipient survival, which was compared with 4 degree and 10 degree. You can see almost both the patient group has a equivalent survival. This is the what helps in keeping the lungs constantly at 10 degree, that is export care, where you can see that this is different from the regular what we use for lung preservation. There is no direct touch, there is no direct ice in the box. Instead of that, they are using gel pack, so will not come in directly contact with the ice. Once the lungs are packed in the standard way of three bag technique, then you can, from the app, you can check the ischemic time. You can see constant temperature monitoring, and as well as GPS location. What is the role of ex vivo lung perfusion? So indication of ex vivo lung perfusion: when your donor lung is a borderline, your PF ratio is less than 300, pulmonary edema, bronchoscopy evidence of aspiration infection, poor lobe compliance, logistic issues, DCD donor, research trial donor like HCV positive, EBV positive. Majority, when you go for lung assessment, ICU people overload many of the places. Patient will be overloaded with the fluid, so patient will be in severe pulmonary edema, where ex vivo plays a major role. You can assess lung on the ex vivo, you get a more time to assess lung, and then you can take a decision for a transplant. So how is the future is going towards a lung transplant? You retrieve the organ, keep in 10 degree, you put on the patient on the donor lung on ex vivo lung perfusion, evaluate the lung, again put on 10 degree storage, and you can go for the transplant if the organ is good to go. Fundamental challenge with the standard approach to organ preservation. Cold flush preservation has been cornerstone of success of organ preservation. All the protective cold hinder the possibility of active metabolic process and repair, but this will slowing the down death of the organ, but does not helps in to improve, or you cannot assess patient organ properly, where ex vivo plays a major role. This is the Toronto ex vivo lung perfusion system. How they do is that they procure the lung, they transport the organ to the uh, recipient hospital where they keep the lungs into a chamber connected to ex vivo circuit, which has a pump and a deoxygenator membrane and leukocyte filter. And instead of using sweep, they use a reverse sweep where they will reduce the O2 and deliver CO2, and they will connect it to the ICU ventilator. This is the what it looks nowadays. TAREX. This is the TOREX lung perfusion system. This is the most advanced system which nowadays Western countries has adopted. They can assess lung with AI and multiple inflammatory markers to know how the lung will respond after the lung transplant. What markers they use is interleukin 6, interleukin 10, interleukin 8, and interleukin 1 beta. This you can see the everything on the screen itself. You can measure the all the four inflammatory markers, and based on that there is a scoring system which will let you know whether your lung is will show a better outcome or a poor outcome. It will show in a high risk transplant, good to go transplant. This is the X-ray taken on the ex vivo lung perfusion. You get an advantage to do bronchoscopy. On a ex vivo lung perfusion. You can do gene therapy. This is how it looks when a human lung is connected to ex vivo lung perfusion. This was the major trial was done, HELP-2 trial. 1019 total 1000 patient was studied, which showed whatever borderline lungs was kept on the ex vivo, 70% of the lung were improved from what they have procured, and they underwent a lung transplant. This is how lungs look on ex vivo and X-ray shows on lungs. You can study multiple parameter, pulmonary artery pressure, you can study delta PO2, glucose, lactate trend, you can see how ex vivo lung perfusion is a different from other existing lung procurement system. It has a perfusate flow of low centrifugal acellular with the normothermic temperature with low ventilation strategy and perfusate CO2 supply required. Always to keep low flow is a better, which helps to prevent any endothelial capillary injuries in the lung. This is the data which was relieved from 2008 to 2020, which compares the graft survival on ex vivo lung perfusion compared to non-ex vivo lung perfusion, which are equivalent same. Outcome of transplantation of lung preserved more than 12 hours is equivalent same compared to those which has a less ischemic time. You can see 90 days mortality is also equivalent same. There is a two mortality which was not related to PGD. How number of transplant has increased with ex vivo lung perfusion. You can see in the early 90s and 2012, there was no increase in the lung transplant. After adaptation of ex vivo, there was an increase in donor pool, giving advantage for a logistic to travel a long duration, assess the lung properly for a borderline lung, and you get a more donor for a waiting patient. Extended preservation time with ex vivo lung perfusion. So normothermic ex vivo lung allow for prolonged total preservation time, includes 2 periods of protective cold ischemic time. First, you keep in a cold ischemic time of 10 degree, then kept in a ex vivo lung perfusion, then again in a cold ischemic time, then lung is transplanted. So how often you can do, how many cycles of this you can do? You with this you have advantage of doing, you deliver antibiotic, you can do biological gene therapy, cell therapy, immunoclocking, inhale gas monitoring, So this was studied on a lung where this was studied on a pig lung where multiple cycles of uh, cold and ex vivo lung perfusion was done for 3 days. They have done first 6 hour cycle was with 4 degree, then another 18 hours cycle of 10 degree. Then they have kept on ex vivo lung perfusion. Then another 20 hours of another cold ischemic time of 10 degrees. Subsequently, they did for 3 days, which after 3 days of preservation, pig lung was transplanted. So you can see the lung which was transplanted, only unilateral lung was transplanted, which was compared with the contralateral lung. You can see PF ratio of the lung transplanted was equivalent good or in fact better than the non-transplanted lung. So it gives a hope that even it can be done for a human where you can extend the lung preservation time with. So what are the important consideration in lung preservation in 2026? Donor consideration, recruit lung, attention to preservation, lung anatomy, dual circulation, parenchymal and bronchial circulation, flush with Perfodex solution, integrate and retrograde, store in flush solution, keep inflated with 50% O2, aerobic hypothermia. Storage temperature 10 degree has become the standard. Role of ex vivo lung perfusion, evaluate and repair lungs. Concept of preservation must be continued during implantation and reperfusion. Thank you, sir.
Nice presentation, Deep.
Thank
A
you, sir.
lot of things have changed from the time when I was in Toronto for about a month or so when I was with Shaf at that time. That was way back in 2009-10. And they were doing the ex vivo, this thing, it was still in the experimental stages and they were not using that routinely. And maybe I think last year or so when I met Shaf, then that was the time when he told me that they are doing everything as elective cases nowadays with transplant doing in the daytime, and so that the regular list is not deranged. So that is the thing. The one important thing, although with all these techniques, is the initial assessment is very important, I think. And when you choose or accept a lung for transplant, and for residents, I would like to tell you that you should follow this nomogram A, B, C, D, E, F. I always tell you before you close, you have the same formula. A would be airway pressures and ABG. B should be bronchoscopy before you are accepting the lung for transplant. C would be to evaluate the chest X-ray and the CVP at that time. When you go for harvesting at the donor hospital, then on table you have to check for deflation of the lung so that you see the compliance of the lung before you accept it. And then E, examination, palpation and visualization of the lung. And F is the flush, which you do. In nowadays, we used to do the same Perfodex. But now with the newer techniques and newer preservation techniques, I think the results are better. I think Dr. Basha would be better to tell us the present situation and how we can improve further with our results. Dr. Basha?
Yes, sir. Good morning, everyone. And Deep has tried his best to cover what is happening in field of lung preservation. Lung transplant has multiple challenges, starting from donor selection to recipient. And if you go with the physiology of lung preservation, definitely EVLP and then this 10 degree. 10 degrees, all the idea and concept came from 1980s. and now it is rapidly used across different centers. We know that around 30 to 40% of the people used to get PGD, and one of the risk factor was how you preserve the lung. However, there are challenges in our country as compared to other. It is just not the PG. The first is how we take the care of the donor in our ICUs. So that's a big challenge, and most of them are having infection beyond 3 days and 4 days, and we are still looking for that elusive thing which can address this problem. Donor lung at 10 degree, definitely it is going to be game changer as compared to EVLP. It is less expensive, and we can go for slightly more distant retrievals. However, once most of the places beyond Bangalore, when we get a call of donor like from Dharwad or from Mysore, the neighboring cities, it is extremely difficult for us to get even a CT, and they are not taking good care of the lungs. So these are infected lungs for which there's no great utilization. EVLP, again, it is an expensive proposition. Even Dr. Sandeep's team tried, but later on, nobody is actively doing right now because of the cost and all. Toronto program, the number increased because they are using a significant number of DCT donors, and for that, it helps them to do an evaluation and all. And they go for distant retrieval for decision making and all. The challenge is we bring a lung and we do on EVLP, and subsequently, if we decline the lung, who is going to bear the cost? And it requires lot of manpower. The results, the story behind that is requires lot of manpower, and unfortunately, most of us are occupied with our clinical work, and this is unaccounted. So these are the challenges. However, I see maybe things will change better with a lot of new breed of cardiac surgeons coming and showing a lot of interest. So these are the points from my side.
Do we have a system for maintaining at 10 degrees, Basha, now?
KIMS team is using, they have designed their own. Right now, we are not using, and there are a couple of indigenous startup who are willing to do even basic science workup so that it gets approved. But KIMS team is routinely using.
Maybe like nowadays we see a lot of these refrigerators that are available, small size refrigerators with
Yes,
some
sir.
sort of electronic devices where you can have a thermostat within that and then use it at 10 degrees. Is that possible? Is that a way
Yes.
to go in our country?
Yeah, looks like it's a. And as I said, in Hyderabad and Chennai, both teams there are a startup who has invested a lot, and this whole idea is not just for lungs; it is going to kidney, liver, and all. So it is worth considering. Only thing is, yeah. So people are trying this. Definitely, it is not a idea is excellent and it is proven, and for our country, this is the need as compared to EVLP.
Yes, I think that is the more practical and then
Yes.
maybe more useful. Okay, thank you for
You're
your
welcome, sir.
comments. Any comments, sir?
Only thing is, I always told you, you must tell the statistics of Narayana Hridaya. When did we start that? How many total we have done and our research? Because we are beginners in this field. We must have been using the 1 to 4 degree centigrade preservation at that time, and then the time from harvest to the implantation should be less than 5 hours. Whereas the EVLP and 10 degree made a lot of change. It's about 10 to 12%. And so availability of the donor has increased, as you showed in the graph in Toronto from 2010 or 2012. The other thing you should have, this is a highly specialized subject. You should have told us about the normal approach for lung transplant, For a lung transplant, maybe single, maybe double, maybe a heart lung transplant. And single transplant is usually approached from the thoracotomy, whereas a double transplant is always by a clamshell. And whether it can be done, a single transplantation can be done without CP bypass or without ECMO. It can be done in certain cases. And the advantage of doing it without cardiopulmonary bypass is that the bleeding is much less and the cytokines and the inflammatory markers will be raised because of the cardiopulmonary bypass, So, and also the new 10 degree with EVLP, I think, we don't have EVLP, no?
Yes, sir. We don't have.
Okay. In Hyderabad and Chennai, do you have that?
No.
They tried, sir,
No.
but every time getting EVLP is not a task for a hospital, but it comes with a reusable kit, which itself costs 10 to 15 lakh for every lung you keep on EVLP, which is not
Okay.
affordable.
Yeah.
And how many transplants we should have?
Yes.
It's a very rare thing, So
Yes, sir. I'll add couple of things. So we are now able to do 6 to 8 for in a year, and from last 1.5 years. So initially it was done on CPB. Then we changed our strategy during last 2-3 years to VE ECMO, and we have attempted with the better selection of the recipient and donor. We have attempted even off pump, and we can see the difference. So our rate of PGD blood transfusion has come down once we moved from CPB and all. Right now we are hovering at 1 year. So we are crossing 35 to 40 total, and we are reaching 1 year of survival of around 70%. And infection is still plays a big decider besides PGD. So these are the two issues where, and one of the problems is by the time the patient comes to us, they are delayed referrals, and they have very significant high PA pressures and all. So it becomes difficult to do them off pump. So these are the challenges. So it's a whole team has to grow across the country. People need